Hi, my name is Jonathan Johnson. I'm the medical director of the Pediatric Heart Transplant and Heart Failure programs here at Mayo Clinic. Here today we're going to talk to you about heart transplantation, but specifically talking about patients with failing Fontan circulation. In this talk, we'll talk a little bit about both children and adults as it pertains to our Congenital Heart Center. So, as many of you know, and you can see on the screen, the Fontan circulation can consist of many different variations. The image on the left shows the Glenn connection, where the SVC is connected to the pulmonary artery. The middle picture shows the original Fontan operation that was performed in the 70s, 80s, and early 90s, which involves the right atrium connected directly to the lung arteries. And then the image on the right shows the more modern operation with a synthetic tube connecting the inferior vena cava up to the pulmonary arteries. This can be done either inside or outside the heart and is typically termed either an intracardiac or lateral tunnel type of Fontan, or an extracardiac Fontan if the tube is outside of the heart. Now, when we're talking about patients who might need transplants who have a history of Fontan circulation, we're specifically thinking about patients who have one particular type of symptoms. Either their current Fontan circulation is working quite well, but they have ventricular dysfunction, where the ventricle or squeezing chamber of the heart is not squeezing well enough. There could also be other anatomic issues, such as one of the valves in their heart leaking quite a bit, causing significant problems. There's also a couple of maladies that are very specific to the Fontan circulation called protein-losing enteropathy or plastic bronchitis. In protein-losing enteropathy, patients lose protein through the lining of their gut wall. We can measure this by measuring the amount of protein that we actually find in their stool. Unfortunately, what happens is that the amount of protein in their body gets wasted over time, and they can develop a lot of side effects from this. Typically, this includes a poor growth. They tend not to go through puberty nearly as fast as other patients. They can develop fluid accumulations in their belly as well as in their lungs, and overall can be quite sick. Plastic bronchitis is kind of the corollary to that, but specifically they lose protein in their lungs. And when the different proteinaceous fluid is secreted into their lungs, it tends to collect and then form these casts that can block their lungs. This can be quite life-threatening and typically needs emergent medical attention whenever this happens. In recent years, transplants become a very prominent way to treat protein-losing enteropathy and plastic bronchitis. Our center, as well as many other centers last year, put together our information to try to look at how well patients did after having a transplant who had a history of protein-losing enteropathy. And fortunately, over 95% of them, the protein-losing enteropathy completely resolved once they had a transplant. Now, what we don't understand quite well yet is what the role the liver plays. There are some patients who have ultimately required having both a heart transplant and a liver transplant with their history of a Fontan. There are also patients who have needed only a heart transplant, and then whatever liver issues that they have had have resolved after their heart transplant. And we don't have a great sense yet for exactly what point the patients might need to have that second organ or not. Overall, though, no matter what happens and no matter what indication is coming from an anatomic or a symptom perspective, the biggest thing that prompts one to think about transplant is a patient who has significant symptoms where it's affecting their quality of life. They can't work, they can't go to school, they have significant symptoms pretty much whenever they are moving or doing anything beyond daily activities. And all of these things are a significant indication for going ahead with heart transplantation. Now, specifically talking about heart transplantation, as you can see on the screen, there are two different techniques that we've used in the past for doing the surgical part of the transplant. As you can see on the left side, there are suture lines in the red tube, which is the aorta, the tube just to the right of that, which is the pulmonary artery, as well as to the left of the screen in the atrium itself. On the right-sided picture, you'll see suture lines above the atrium in the superior vena cava and the inferior vena cava, the blue tubes on the top left and top bottom of the screen. These are two different ways that one might put the new heart in once you've taken the old heart out. As you can imagine, in many patients who have had a Fontan circulation, they have a single ventricle physiology, meaning part of their heart is missing. They may not have an adequate pulmonary artery. They may have an absence of one portion of a valve or a ventricle. Sometimes they can also have vessels that occur either not at all where they're supposed to be, or there can be vessels on both sides of the body where there should only be one. One example of this is the superior vena cava, the blue tube on the top left of each image. Typically, in most patients, we only have one right-sided superior vena cava, as you can see in this image. However, there are patients who have superior vena cava on both sides of their body. This takes a little bit of a different technique to put the new heart in, as we have to make sure we are able to drain the blood coming from the left side of the body as well as the right. In every Fontan patient, we typically do CT scans to make sure that we understand their anatomy fully and make sure that we can visualize making the connections beforehand. This typically now involves using the CT scan images that we have to create 3D models, both electronically, as well as we can do 3D printing to make the models and look at them with our surgeons in our hands to try to figure out what the best way to put the new heart is going to be. Heart transplant survival after Fontan classically was thought to not be as good as other patients who required heart transplantation. However, as you can see in this graph here, in fact, patients who have required transplantation, either for pediatric purposes or in patients who have adult congenital heart disease, is actually as good, if not better, than what has been reported nationally for other patients who have been transplanted. In more recent years, especially in the pediatric community, we now think that patients who have a transplant for a history of a Fontan circulation should do just as well as any other patient who has a heart transplant. Now, I would be remiss to give this presentation to you all without talking about the potential complications that can also happen in a patient who has a heart transplant. Unfortunately, a heart transplant is, again, a palliative procedure, and it's a temporary procedure. A new heart only lasts about 15 years in the average adult. And if we transplant a neonate or a baby, it tends to last a little bit longer, but it's still only around 15 to 20 years. And so typically, first of all, we're talking about giving a patient an operation and giving them a new heart that's only going to last them about 15 years. This means at the end of those 15 years that we have to be talking to those families on average at that time about a second heart transplant, or even a third if they've had two in the past. There are many other complications that can happen after heart transplantation. In patients who have a Fontan circuit or have a failing Fontan circulation, there are many perioperative risk factors. It's very important that your transplant be performed at a center that has experience in transplanting patients with a Fontan circulation, as a lot of the specific connections that need to be made can often be unclear and can be difficult. Further, there are different complications, including bleeding, that tend to be a slightly increased risk in patients who have had a prior Fontan operation. And because of this, we need to be really careful when we're doing the transplant to manage our blood products appropriately. Patients who have had a heart transplantation unfortunately have to be maintained on many medications after transplant to suppress their own immune system. This is to allow them to tolerate the new heart. Unfortunately, one of the side effects from those medications is kidney dysfunction. And somewhere between 2 and 5% of patients who have had a heart transplantation ultimately actually need a kidney transplant as well, because the medications that we've given them to help their heart transplant have unfortunately harmed their kidneys. As you can imagine, if we suppress your immune system, you also are at an increased risk of infection as well, and we manage patients very closely and cautiously after transplantation because of this. We typically see patients regularly after transplantation. Early after transplant, we see patients 2 to 3 times a week, and even when they're doing well many years after transplant, we still see them at minimum every 6 months. One unfortunate but rare thing that can happen after heart transplant is cancer. There's a rare type of cancer that occurs because a particular virus gets activated in one's bloodstream. And typically this is maintained by our own immune system and is kept down. And unfortunately, when we suppress the immune system, this can become an issue. This can cause a slightly increased risk for lymphomas in patients who have had a heart transplant. We watch patients very carefully, measuring levels of those viruses in the blood on a monthly basis early after transplant, and keeping a close eye on them many years after transplant to make sure they do not develop these type of cancers. All patients after a heart transplant should also have a dermatology visit at least once a year for a skin exam to make sure that they've not developed any skin cancers. Lastly, coronary artery disease can happen in patients who've had a heart transplant. This is not unique to the patient who's had a Fontan, but is a characteristic of all patients who've had heart transplants. And this, in fact, is the reason that many of the patients' hearts only last 15 years. Many different strategies have been tried to reduce the risk of the coronary artery vasculopathy from advancing and causing a limiting of the life of the heart. We've started several different immunosuppression medication protocols here, which we hope in the future will reduce the risk of this happening and hopefully will extend the life of the graft significantly. I'd like to thank you all for your time and thank you for joining us today as we talked about heart transplantation in patients who have had a failing Fontan circulation. Please feel free to contact us at any time if you have any questions at all about this, and we look forward to seeing you.